Hello and welcome to another Case of the Month session. And this time I'm going to be presenting you something that's not heme related at all or nephropathology related, but it is a bone marrow biopsy sample, and we have a 12-year-old girl this time, and she presents with left hip pain. So after a course of antibiotics, because her symptoms don't resolve, an MRI is performed. Over there, the MRI shows a destructive 10 centimeter mass involving the sacral vertebra and invading the sacroiliac joint, and with their numerous bone metastasis. The patient also happens to have pancytopenia, so the clinicians go like, why don't we hit two birds with one stone and perform a bone marrow biopsy instead? They think it's like simpler, you don't have to bother with invasive radiology, they can do it themselves. So they go, okay, and we'll have staged the patient, and they perform a bone marrow biopsy. So this is the bone marrow biopsy sample I'm going to be showing you. The biopsy, actually most of the fragments in it are like blood clots, but there is this one fragment which belongs to the bone marrow, but this is, you can see that it's fragmented, there's crush artifact, and you can appreciate even at low power that probably some of these cells are necrotic, and you go like there's probably an infiltrate, but what kind of neoplasm are we dealing with? Some of these cells are like barely viable, and it's difficult to tell exactly what we're up against. Here you go, here they are, and there they are. You've got these large typical looking cells. They're mononuclear, but as I said, it's very difficult to diagnose anything with it. But then again, luckily the aspirate is perfect, and in fact it's diagnostic. Okay? At least, well, even if you can't really name the neoplasm, it's very easy to at least tell that this is some sort of metastasis, because over here you've got clumps of small round blue cells, and you can see that they're actually forming clusters and clumps, and there's nuclear molding and everything. I'm going to zoom in now. There they are. They've got really large nuclei, and the chromatin, it's blastic, it's got very thin basophilic cytoplasm and lots of cytoplasmic vacuoles. And of course immediately I go, okay, this is some sort of metastasis, and the girl having a bone mass, the initial differential diagnosis is Ewing sarcoma. So what I do is, which I'm going to show you in a minute, I just want you to appreciate the cells themselves. A FISH analysis for EWSR translocation. I'm going to show you the result of that right now. See, here they are, the neoplasm. They do not look like heme, at least classical leukemic cells. You can see that they've clustered, there's nuclear molding, and this is the FISH analysis results, where in these neoplastic clusters it's very easy to find the EWSR breaks, which helps us confirm our initial presumption of Ewing sarcoma. I of course turned the case on to Kemal, my roommate, for the actual sign out. Here's the CD99 stain. I'll show you that as well. It's diffusely positive. There's also focal positivity for NKX2, as you can see here, focal areas. But the point being that the aspirate is what actually led us to the diagnosis, and with just this biopsy sample, it would have been very difficult to diagnose. So I hope you enjoyed this case, and see you next month. Bye bye.